I'm Katrina Davis. I'm actually a urogynecologist with Sarasota OBGYN Associates, but my main office is in Port Charlotte. And I spend one day a week in Sarasota. I'm on the MHI board. That's how I know Dr. Merritt and Dr. Aday. I'm also with Gulf Coast Medical Society. But I was asked to do this training. I thought we'd start off just with a little bit of background about breast cancer and why are we doing this, very brief, and then we kind of run into the exam, which is going to be interesting. I was telling Onyx, I've never done this on Zoom. Usually it's in person with some models and, some tactile feedback, but we're going to make it work. So I've got some slides. Let me pull them up. Let's see here. Start the first one. That didn't work. Wait a second. Let me make sure I'm on the first slide. Sorry about that. All right. So we're going to talk about breast cancer screening in general and the self-breast exam. And then after it's over, we'll have a question and answer session. So I always start off with making it real for everybody. So these are just some celebrities, and there are a bunch of them who have had breast cancer and publicly talked about it. And all of us probably have someone in our family or personal history. I have a grandmother. My father's mother passed away with recurrent breast cancer. I have an aunt on my father's side with breast cancer. And then I had 3 abnormal biopsies and ended up with a double mastectomy about 10 years ago to prevent me from developing breast cancer. So it's pretty common. And it's actually the most common non-cutaneous, so not skin cancer. And it's the second most lethal form of cancer among women in the United States. And it's second only to lung cancer, followed by colorectal cancer. And in general, the chance for a female in the United States to be diagnosed with breast cancer in her lifetime is 1 in 8. Why is it going backwards? Oh, I see. My fault. So the overall risk is 1 in 8, but this is a breakdown by ethnicity. So 13% risk in the white population. For Black women, 12%, Asian and Pacific Islander, 11%, same with the Latinas, and then Native American women, 8%. And risk factors. The older we get, the more likely we are to develop breast cancer. The earlier age when your period starts, and older age when you first become pregnant. And we've all heard of the use of hormone replacement therapy being linked to an increased risk of breast cancer. Having dense breast tissue, family history, and genetic mutations. Having had radiation to the chest, actually, and being overweight and not exercising are all risk factors. There are different breast cancer types. Here we've got the breast, just to give a brief overview. So you've got the nipple, and you've got the lobules, where milk is produced in ducts where it's transported and then expressed through the nipple, and then the areola, that flat skin that surrounds the nipple. So you can have cancer that's intraductal, meaning in the ducts, intralobular, which means in the lobules, and then there are different types such as phylloides, angiosarcoma, Paget's disease, inflammatories. There are many different types of breast cancer. And then it can be what's called carcinoma in situ, meaning it has the machinery. It can spread somewhere else, but it hasn't yet. And invasive cancer means it has started to spread beyond its initial location. And then metastatic, it's left the breast and it's gone to other organs. In general, the general treatments, there's surgery, there's radiation, chemotherapy, and if the cancer has hormone receptors, then anti-hormonal medications can work. There are new targeted therapies that attack specific proteins within the cancer, and then immune therapies that actually boost our own immune system to fight the cancer better. And the good thing is 5-year survival rates are good overall, about 89.2%. If it's localized, it's even better, 98.6%. And once it starts to spread a little farther, then now we're at 83%. And then metastatic disease spreading to distant organs, now we're down at 23%. So the goal is to prevent that spread. So breast cancer in the United States, you have about 264,000 cases in women and then 2,400 in men. Out of those, 42,000 women die and about 500 men die in the United States every year. But what's interesting, you remember that first chart I showed you, in Black women, we're not, compared to white women, I believe it was 13% incidence in white women and 12% lifetime risk in Black women. However, still Black women are 40% more likely to die from the breast cancer, even though we're not, it's not as common in us as it is in white women. So why is that? Black women tend to have more aggressive cell types, such as triple negative. That's a determination of what types of receptors are positive. Black women tend to present later in the disease process, and we're going to talk about why that might happen. And then we tend to be diagnosed with breast cancer at a younger age than white women, with a median age for Black women of 59 compared to 63 for white women. Other issues, implicit bias, which I'm sure we're all familiar with in healthcare providers. This isn't something someone intentionally does, but underlying racism and prejudice colors, no pun intended, colors how we treat patients. Lack of insurance, lack of understanding, a mistrust of the medical community, such as the history we have with the Tuskegee experiments, and then fear of treatment and its implications. What is that going to make my body look like? Will I still feel like myself? These are all things that slow us down in seeking out treatment. So what can we do? As I mentioned before, early diagnosis equals survival. So the earlier you find the cancer, the more likely you are to get treatment when it's early in its stage, and therefore your likelihood of survival is much better. So things we can do to diagnose is our self-breast exams and mammograms. Now, just briefly to run through guidelines, and typically the average risk woman can go and get her mammogram starting around 40 to 45 and get them annually. If you're in a high-risk population, that's those people with genetic predisposition, like you've got a lot of family members with it, or if you've been tested and known to have a genetic predisposition, then you want to start a little earlier, around the age of 30. And in addition to mammograms, you typically get breast MRIs as well. On top of that, though, something we can all do is once a month, we can do our own breast exam. And we're noting that 40% of diagnosed breast cancers are detected by women who found a lump in their breast and then presented for treatment and for further evaluation and then diagnosis. Now, mammograms can help detect cancer before you can feel a lump, but breast self-exams help you to be familiar with how your breasts look and feel, so you're alerted to when there's a change, and therefore you alert your healthcare provider. So how should the exam be performed? One way is in the shower, and we take the pads or the flats of our 3 middle fingers, and we check the area, breast and armpit area. You check both breasts each month, feeling for any lumps, thickening, hardened knot, or any other breast change. Also, standing in front of a mirror, you visually inspect your breast with your arms at your sides. Next, you raise your arms high overhead, and you look for any changes in how the skin looks, the contour of it. Is there some dimpling? Are there changes in the way your nipples look? You can place your hands on your hips and just kind of get a sense of, do they match? Now, it's very common for us to not have total symmetry. So the breast, left and right breast may not look exactly the same, but the more you do this, the more you'll know what's normal for you. And then look for any dimpling, puckering, or changes, particularly on one side or the other. And finally, you can do an exam while lying down, and the breast tissue spreads out evenly along the chest wall when you do this. And sometimes you can feel something lying down that you can't feel when you're sitting up. That's why your healthcare providers typically will examine you both while sitting. I know I do. And then I examine the patient again while they're laying down. You place a pillow under your right shoulder and your right arm behind your head, and use your left hand moving the pads of your fingers around your right breast, gently covering the entire breast, including under the armpit. We forget that that breast tissue extends into the armpit area. You want to use light, medium, and firm pressure, like variations of it. That way you get the different depths of the tissue. You want to squeeze the nipple, make sure there's no discharge, no lumps, and then you do the same thing on the opposite side. There are different ways to cover the breast tissue, and it really doesn't matter. The goal is to just make sure you cover the entire breast. Some people like to move up and down parallel. You can start in the middle and circle outward, or you can do like a pie. You're coming in. That would be a little harder, I would think, with one hand, but I actually like doing the circles. But it really doesn't matter, whatever is comfortable for you, to make sure that you examine the entire breast. And so the moral is early diagnosis equals survival. So you do mammograms, self breast exams, and then on top of that, once you know, then you have to seek treatment.